Okay, so we're here with John Childs today. Hi, John. Thanks for joining us today.
Hey, Rachel. Thanks for having me. My privilege.
Great. So we are talking low back pain today, and I've asked to talk to you today because you've recently been in Singapore presenting on the Low Back Pain Symposium at the WCPT Congress on treatment-based approach to managing low back pain, and we'd like to discuss that a little bit and talk about that. We'll get on to that in a little while, but first of all, I know that you're an extremely experienced researcher and educator and advisor and receiver of awards, and I suspect you're a really good clinician as well. So I was just wondering if you could tell us a little bit about yourself for the people that haven't met you before, just so that they know who you are.
Sure, you bet. Thanks, Rachel. My name, of course, is John Childs. I'm a physical therapist by profession. Actually sort of grew up within the kind of military healthcare system within the United States. I went to undergraduate at the United States Air Force Academy back in the mid-1990s. I was commissioned as a second lieutenant in the Air Force, and then actually went straight to postgraduate physical therapy training at the U.S. Army Baylor program in physical therapy in San Antonio, Texas. So was there for a couple of years, then was in clinical practice for about 4 to 5 years full-time, and then was picked up to get my by the Air Force to get my PhD, which I completed at the University of Pittsburgh. And it was during that time, in the early, from about 1999 to 2003 or so, when at Pittsburgh were individuals like Tony DeLito, Julie Fritz, and others who became some of my foremost mentors and colleagues in research. And a lot of the early research into the development of some of these low back pain classification systems, clinical prediction rules, et cetera, were becoming sort of the new wave, if you will, in terms of thinking about managing back pain. So that's where I sort of cut my teeth from a research perspective. And then for the sort of the latter half of my career, was on faculty in the Army Baylor program in San Antonio, so where I had went to school, and continued to collaborate with a number of folks in classification-based research, and more recently doing a lot more health services related research, looking at big data, right? Processes of care, how patients navigate through the healthcare system, and how do we steer patients to the right treatment, the right provider at the right time. And so that brings us kind of to recent days. I'm now quote unquote retired from the military, believe it or not, but still very much working full time. I'm currently the CEO of a company called Evidence in Motion. Many of the listeners might be familiar with what we do. We provide a number of certification, residency, and fellowship programs for therapists in everything from orthopedics to manual therapy, geriatrics, a growing variety of practice specialty areas. So that's a little bit about my background. I'd be remiss not to say I've got a beautiful wife and five children, all the way from 16 years old down to 5 years old. So it's quite a busy time of life.
Yeah, so I'm not sure how you managed to fit in all that research and educating and clinical work as well. So it sounds like you have a very busy life.
Well, it takes a team effort, and one thing I learned a long time ago, and some advice I got early on: associate yourselves with the best in the business. Hang on tight. Don't really care much about who gets the credit. Try to put egos to the side, and it's quite amazing what you can get done when you've got a group of colleagues that are interested in doing cool stuff together. So it's fun.
And that's an amazing tip to start off with, I think. Amazing piece of advice for everyone.
Sure.
So I think we'll get on, if it's all right with you, we'll get on to the treatment-based approach concept in a little while. What I want to start just to ask you first of all is just a general question. What do you think is the most powerful piece of knowledge that a physio can have as that low back pain patient or that back pain patient walks through the door? What kind of things should they be thinking about just as that patient comes in? What's the most prevalent thing that should be in their mind?
Well, I think let me say first of all what I used to think as a young, naive therapist 10, 15 years ago. I used to be extremely focused on not so much the patient, but some presumably underlying pathology, right? It was this pursuit of, is it a joint? Is it a disc? Is it a facet? And getting very sort of wrapped around this whole notion of pathoanatomy and trying to quote unquote fix the patient's problem. And now having been at this for 15, going on 20 years, and appreciating just the voluminous amount of research suggesting that we've lost the art of appreciating that it's the patient that is sitting in front of us, not the spine. And so I think the from a 30,000-foot perspective, I think what therapists really have to appreciate is that you have a human being that's sitting in front of you. This human being is in pain, and we understand very, very little about what may be causing their pain. But have a growing appreciation, right, that that pain lives inside the patient's brain, and that the way we educate, talk to, communicate with, demonstrate empathy towards all of those quote unquote intangible psychological and other factors play a huge role in the patient's recovery. So I'm much less interested in a patient's sort of pathoanatomy than I am in the patient's a lot of the non-clinical factors that we oftentimes under appreciate.
Yeah, and I suppose when we're thinking about sort of biomedical models and things, it's important to incorporate that aspect as well at any time. Really good advice not to forget that sort of thing.
Sure, yeah, absolutely. And at least here in the United States, it's different obviously in other healthcare economies around the world. But the biomedical model for back pain, at least in the U.S., has been a complete disaster. We spend north of $80 billion a year in managing back pain. We poke it with needles, we surgerize it, we inject it, we give all sorts of drugs, and it's a real travesty. It's one thing if you just look at the economics, the costs, but it's another thing when you take a group of healthcare professionals where we're charged with, first of all, doing no harm, and unfortunately inflict lots of unnecessary harm. And I don't mean that providers, physicians, or physical therapists or anyone has any ill intent. That's not what I'm suggesting. But in this sort of unending pursuit of a biomedical model, we've completely over-treated back pain with many interventions that are very expensive and oftentimes pose far more risk than benefit.
And so a lot of your work has been around developing this concept of the treatment-based approach to managing conditions, including back pain. So I was wondering if you could you just tell us a bit about the treatment-based approach for people that haven't come across it before, and how that fits into what we've just been talking about.
Sure, you bet. So, treatment-based classification in its sort of most generic sense, I would sort of distinguish it between sort of pathoanatomic diagnosis, right? So rather than sort of focusing on the disc, the facet, rather than diagnosing a condition, what we're more interested in is looking for patterns of signs and symptoms that the patient demonstrates either through self-report, patient interview, or potentially physical exam findings that are associated with benefit from a particular treatment intervention, right? So if we look at the purpose of why we examine and treat the patient in front of us, right? It's ultimately to try to reduce their pain, improve their function, mobility, and those sorts of things. So wouldn't it be nice if we had some sort of a decision-making scheme that would help us categorize patients not so much based on pathoanatomy, because that's proved to be relatively fruitless at this stage, but rather based on a cluster of signs and symptoms that when you see that pattern, it sort of prompts you down a particular treatment pathway that has increased odds of success compared to some other form of intervention. And so that's treatment-based classification in its most generic sense.
And how would someone use that treatment-based approach with a patient that was sitting in front of them?
Sure. So, first of all, to be clear, right, there's different sort of classification schemes that have kind of evolved over the last number of years, each of which has some unique nuances, advantages, strengths, weaknesses. The system that I sort of grew up in was the system that was developed actually originally at Washington University in St. Louis. Tony DeLito often gets sort of credit. Oftentimes this is called the DeLito sort of classification system, if you will. His mentor, and Tony would be the first to say this, his mentor, Steve Rose, was one of the real early sort of pioneers, if you will, of this whole concept when Tony was at Washington University in St. Louis. And so individuals like Tony, Dick Earhart, and others started exploring this whole concept. And the original, classification system back in the, early to mid 90s, had a lot more categories in it than it does now, right? They were sort of envisioning this on the back of a napkin, probably after a few sort of choice cocktails would be my guess, and of course then that system has been subjected to more rigorous research over the last number of years, where we've ended up now with about, depending on how you count them, 3 to 4 categories, right? We have this category of patients who seem to benefit from a more heavy manual therapy sort of an approach, of a manipulative, hands-on approach. There's a category of patients who seem to benefit more from an intensive strengthening, stabilization-based exercise approach. There's another subgroup of patients who benefit from repeated movements, right, where we're looking for a directional preference, typically patients who might have more distal symptoms, and we exercise them in a direction that helps to centralize their symptoms. And then there's a smaller sort of fourth subgroup of patients who seem to benefit perhaps from traction or distraction sort of oriented exercises. For example, patients with distal symptoms, they don't really centralize so much with repeated movements, and those patients tend to benefit from traction. So from a clinical perspective, the way you use this system is, as you examine the patient, you consider their signs, symptoms, their interview, and begin to sort of think about which of those subgroups the patient best fits, and then begin to align your initial treatment around that category.
And so that brings 2 questions to my mind. One is this where clinical prediction rules come into the subgrouping of patients?
Yeah, it is. So as these categories kind of started to become more and more refined, from an initial 8 or 9 categories down to 6 to 7, down to 4 to 5, it became incumbent. It became more necessary to really try to articulate more precisely exactly what the criteria were that would best describe these different categories, right? For a classification system to be ultimately useful, the subgroups need to be somewhat mutually exclusive. In other words, if a patient fits 3 different categories, it doesn't really help you as a clinician decide in which direction to direct your treatment. So we've known for some time that these patients, there's a subgroup of patients who benefit from manual therapy, and they seem to be patients that are, maybe a little more acute, maybe they're a little stiffer, maybe they have some of these positive SI asymmetries and those sorts of things. But but in the early 2000s, there was really no definitive set of criteria to validate that, yes, in fact, here are some factors that predict a response to manual therapy. And so the manual therapy subgroup was one of the first subgroups to be subjected to this derivation and validation of prediction rules. And you have to bear in mind sort of the history of where we were as a profession with respect to manual therapy, at least in the United States and certainly in other countries around the world. Manual therapy was a relatively new intervention to physiotherapists. In the United States, it's something we had only been doing for the previous perhaps 20 to 30 years. We've got to credit Stanley Paris for bringing a lot of manual therapy training to the United States, and during that time, a lot of these different philosophies of how you apply manual therapy began to develop, and all of these different schemes, right, were very quite complex, right? It required a fair amount of mental gymnastics where you were trying to diagnose these very nuanced biomechanical dysfunctions, if you will, and then apply presumably a very specific manual therapy technique directed at each of these biomechanical dysfunctions. For example, I grew up in sort of the osteopathic model with the likes of people like Phil Greenman in the Michigan State. It was an osteopathic group. And I practically had to go to the courses 2 or 3 times because it was so complicated, right, that I almost needed a graduate degree in just biomechanical, diagnosis. And all of that was very well intended in the sense that it got therapists putting their hands on patients in a way that we had not previously done so, and that was very beneficial for our profession. But these systems were very disparate, very complicated, and we began to realize that many of the underlying principles of these systems were a bit flawed. That the notion that we can really detect movement, for example, in the SI joint. If you've ever done gross dissection of a cadaver, I mean, it practically takes a chainsaw to even dissect down to the SI joint, much less kid ourselves that we can detect movement at the SI joint with our thumbs so far removed from a joint that may not even move in the first place, right? Depending on your perspective. And if it does move, it only moves in very, very, very few degrees. And so these systems, although they were getting therapists to use these techniques, in some cases, they were discouraging therapists to perform manual therapy because they were so complicated. And so it was almost giving the impression that manual therapy techniques were beyond the skill set of the novice therapist. And so we became, as part of the development of the classification system, we became very interested in seeing how we could expand the use of manual therapy techniques in the United States, because a lot of therapists were fearful that if these techniques were misused, they were going to cause harm to patients and those sorts of things, when none of the anecdotal data bared that out. The risks seem to be far lower than the perceptions of risk. So that's a long way of saying, back in the early 2000s, we started developing these prediction rules, where we subjected patients to standardized treatment techniques. In the case of the manual therapy subgroup, we used a technique that was designed for presumably the SI joint, a fairly, what I would call, generalized technique that's relatively simple to perform. And all patients got subjected to the same technique. And then we started to examine statistically the underlying characteristics that would predict benefit. In other words, the way we defined it was a 50% drop in the Oswestry score over a short period of time. So, in other words, who are those patients that get a dramatic response to spinal manipulation? And that's where the initial set of criteria came from, things like duration of symptoms being less than a couple of 2 to 3 weeks, not having symptoms distal to the knee, in other words, more centralized back pain. low fear avoidance scores, stiffness in the spine, as detected by mobility testing, at least having a certain amount of internal rotation at the hip. And that when you see a cluster of 3 or 4 of those, that then prompts you to utilize a specific technique. And so then similar characteristics were developed over time for the other subgroups. The stabilization category, or the strengthening category, the directional exercise category. And of course, each of those subgroups are in varying stages of development. One of the biggest labels, that has been put on me, and I think inappropriately so, and perhaps we can discuss it further, is that, all I think about are these prediction rules, and that, patient care is somehow is now driven by these algorithms from which you cannot deviate. And that's really not true at all. Some of these prediction rules are still very much in development phase. We need more and more validation studies. The manual therapy subgroup has probably been subjected to more validation studies than any of the other categories. But on the flip side, these systems of thinking, even when they're not fully developed, can still be useful for clinicians. Clinicians need answers for patients today. They can't wait on definitive validation studies to make judgments about what to do with patients. So even in the early phase, these ways and systems of thinking, I think, have use for the everyday clinician.
Yeah, so I'm thinking that maybe, the clinical prediction rules are a great guide to subgroup the patients, but perhaps we can still use our clinical reasoning to fit some patients into a specific group to just see if that will work for them, and maybe not be so strict about it.
Yeah, no, that's exactly right. And in fact, one of the misconceptions about these rules is that, once you're categorized in a category, you're sort of in that category for the rest of your life, and that literally all the therapist does with that patient is, if they're in let's say, the manipulation subgroup, is manipulation. And that's simply not true. Even in the development and validation studies that were being done, patients were also getting active, intensive exercise while they were getting the manual therapy. The point of the categories is not to restrict the therapist from using other interventions. The point of the categories is to really help the therapist get off on the right foot, so to speak. In other words, to begin to make initial decisions about the patient's management that are in the right direction. And because you have to keep it in context of what a lot of therapists tend to do, right, which tends to be more passive kinds of care. What this system was really designed to kind of address was this tendency to use lots of passive interventions, hot packs, ultrasounds, massage, just sort of indiscriminately, when we know that active forms of exercise and hands-on care is better. So if that is the case, let's give therapists some tools and guidelines to help them make the right decisions sooner rather than later. The other nuance I think that's helpful to kind of discuss is, therapists have lots and lots of choices about what they're going to do with the patient. And sometimes when you're presented with so many choices, it almost becomes overwhelming a bit. And so we tend to undertreat patients because we don't know where to start. So the point of classification-based decision-making, again, is to help improve the therapist's judgment by limiting the choices, by helping the therapist to be able to select from 3 to 4 options initially, and then as the care progresses, obviously continue to integrate clinical reasoning throughout and bring to bear other forms of treatment that are appropriate for the patient.
Yeah, I was just about to add, I know you'll have appreciation, and you've already mentioned it, the appreciation for other classification systems and other approaches to treatment and care. And there will be patients that don't fit into any of those subgroups, or perhaps fit into several of those subgroups, and then maybe that's where you go with those patients.
Yeah, very clearly. In fact, one of the known gaps, if you will, in the treatment-based classification system that I'm most familiar with, is that it tends to be most appropriate for acute and subacute kinds of patients, but it's not so useful as much for patients with more chronic back pain. And that's where some of these other systems, especially looking at things like the START criteria and other prognostic factors to try to identify who those patients are that are at risk for prolonged disability, non-recovery, are absolutely integral to a comprehensive strategy for managing back pain. And I think that's one of the hopefully biggest lessons learned from this classification panel that we did recently in Singapore, was that these systems are not designed to be sort of competing systems where, as a therapist, your loyalty should be to, one way of thinking at the expense of other sort of systems. There's actually far more commonalities between the systems than there are differences, and each of the systems brings some different strengths to bear depending on the individual patient.
Yeah, I think that comes across clearly in the video that's available from the symposium. For anyone that's watched that or is going to watch that, I'd recommend it. So with all these classification systems and approaches to treatment available, do you think now that we have a good understanding of causes of back pain and effective ways to manage back pain?
Well, I think we've made a lot of strides. Clinical trials in physical therapy research have just exploded over the last 20 years. We have tons of very high quality data suggesting that hands-on care, very active forms of exercise are far superior to bed rest and patients taking nonsteroidals indiscriminately for long periods of time. And certainly superior to passive forms of care. I will confess a bit of a bias. What we don't know, and what seems to be less clear, is, well, in this realm of manual therapy, which forms of manual therapy work better than others? In this realm of active exercise, is a very quote unquote specific stabilization based approach better than a more generalized approach? And I think sometimes we're almost too critical of ourselves, trying to tease out the nuances of all the differences in the various forms of active exercise, because I think it clouds the overall benefit of rehab, which says, look, any form of active exercise and hands-on care is far better than what happens to most patients with back pain. So whether you're in the transversus abdominis multifidus specific stabilization camp, or whether you're of the mindset that patients just need to be subjected to generalized intensive exercise, both of those are beneficial and certainly relative to a lot of passive interventions that have tended to be used over the last number of years.
Yeah, I think that sums it up, how we've progressed over the last few years. And what do you think the future holds?
Yeah, as I get into the sort of the latter part of my research career, I will confess I'm starting to spend a lot more time in health services related research. If you look at sort of the kinds of clinical trials I've been involved in, I am notorious for sort of pitting treatment A versus treatment B, right? Is high velocity thrust techniques in the lumbar spine better than mobilization techniques in the spine? And don't mishear me. I think all of that data, I think it adds to the body of literature. I think it can help therapists reasoning. But if you really look at where the big opportunities are, and this comment is probably going to be more specific to the U.S., I'm much more interested in helping now steer patients to the right provider at the right point in care. So, like as an example, if a therapist goes to a primary care provider and they're prescribed nonsteroidals, maybe they're prescribed opioids, an MRI or a plain film unnecessarily is ordered, and all of these invasive, high-cost procedures are done. And then 6 to 8 weeks later, now the patient shows up at the physiotherapist's door. Uh, a lot of unnecessary cost has already been expended before the patient ever comes to therapy. And so even when the therapist is delivering, even world-class care, when it's done too late in the process of care, we've really lost the window of opportunity to intervene, right? You have these patients that are at risk for chronicity, and they have high levels of fear, perhaps depressive, symptoms, et cetera, et cetera. A lot of the kinds of things that the START criteria are designed to tease out. We've missed that window, and so even the best care delivered too late doesn't have the kind of impact that it would if that care was delivered up front. And the other kind of interesting concept is that even sort of average care that you and I might look at and say, if that patient was in my clinic, we might do something a little different than that. Even that care, when it's delivered early on and helps to avoid unnecessary pharmacology and drugs and surgery, that's still far better than what a lot of patients are getting for back pain. And so sometimes perhaps we should be less critical of our peers that are using kind of interventions that we might not use, but yet still has an impact on the health system. So health services research, now that so much of a patient's data is in electronic medical records, we can track costs and claims. We have the opportunity to look at these data sets and start to tease out different processes of care. In other words, what are the implications over a 2 to 3 year period of time when a patient shows up to a physical therapist first, as opposed to showing up to a primary care provider or seeing an orthopedic surgeon and only seeing a physical therapist 3 months into the process of care. And those kinds of analyses can really help policymakers start to put physiotherapists in a position where we can have the biggest impact on health systems. And so that's a big area of interest. Still involved in classification-based research, but really it's about getting the right patient to the right provider at the right time.
And I think that's going to be some amazing work that comes out along that line of research, and it's going to really help us to be able to advocate for our profession amongst healthcare providers. And I also think, you talk about it being very United States relevant, but I actually think it's going to be really relevant in many, many countries, particularly low resource countries as well, just to be able to advocate for the profession and build the respect that we'd all like to have for the profession. So I think it's going to be really important, and I'm excited. I know you've published one article very recently, which I'll include, about the cost effectiveness of physiotherapy intervention before imaging, I think it was.
Sure.
So yes, I'm looking forward to this research, and I hope in a few years' time we'll be able to have another chat with you and have an update on that.
Yeah, absolutely. If I could just add sort of one kind of comment in closing, and it's a bit humorous. We had quite a few good laughs between myself and Nadine Foster and Peter O'Sullivan, Mark Hancock, the group of us that was on the panel. One of the real misconceptions, we're obviously each of us very committed to our research agenda. We obviously debate in the literature back and forth on different sort of ways of decision making. And so it's interesting that oftentimes physical therapists around the world can almost get the perception that we dislike one another. And so we had quite a few good laughs at some of the reputation that sort of develops that there may be this sort of animosity between us, and when really nothing could be further from the truth. And so it's each of these systems are not exclusive of another. They each add their own value, and I think one of the best things that came out of the forum was a desire to see more collaboration, internationally amongst these different ways of thinking, to see perhaps if we might be able to develop a more comprehensive system that incorporates the best elements of each of these. So, in any event, in case there's any doubt for anyone who listens, I highly respect and appreciate each of those individuals, and have nothing but the fondest of affection for them, and consider them colleagues and friends.
Yeah, and I think that comes across from the symposium, and it's really nice to see. And I have to say, I think it's really exciting that that if we can create a system that incorporates all of the different classification approaches, then that's going to make a really useful decision-making tool that we can use. Yeah. So I think, respectful of your time, I think we've had a really good, that really helps with our understanding of the treatment-based approach to managing low back pain. I think it will really help to help people to understand it and use it in their clinical practice, and also understand how it fits in with other approaches as well. So really useful, and it's really nice to talk to you about your research and what you're doing in the future, and we look forward to seeing all of that.
Great. Thank you so much, Rachel. I appreciate the invitation, and certainly happy to consider anything else you might need in the future. Appreciate the time.
Great. Thanks very much, John.